Hi, it's Roberta Heal. Welcome to Little Known but Common Impacts of Menopause. It's a webinar that was originally presented on April 3rd, 2024 on behalf of Prime Care Family Health Team in Milton, Ontario. Hope you enjoy it.
Thank you for joining us tonight. My name is Roberta Heal. I'm a nurse practitioner. I live in Sudbury, Ontario, and I practiced here most of my career, my 25 years as a nurse practitioner, but in the last few years have worked at the virtual menopause clinic, which I established to have a wider reach so that women would have menopause care from the comfort of their own homes or where they're living in Ontario or Alberta. I've also have a website with a lot of blogs and, access to videos and stuff for things that I find interesting and related to questions that come up all the time. Some of those things are in the videos and stuff are going to be presented tonight too. I like to ensure that I acknowledge where I live and that this is the land of the Robinson-Huron Treaty of 1850. And I'd like to recognize that I'm located on the traditional lands of the Tikmishing, Anishinaabeg, and the city of Greater Sudbury also includes the lands of the Wahnapitae First Nation. So I extend my deepest respect to Indigenous peoples. Thank you. Okay, so while most people know about menopause symptoms such as hot flashes, of course, that's pretty common, and mood swings, there are many lesser known impacts that can significantly impact a woman's quality of life during the menopause transition. Let's start by looking at estrogen. What happens with estrogen? Well, this is fairly straightforward graph. You'll see in red, estradiol for females goes up during puberty and it goes it doesn't really show how it goes near the end, but it does. And then you'll notice it drops very quickly, quite suddenly, whereas the blue line for testosterone in males drops far more gradually. And even the testosterone line you can see for females, because of course we all have estrogen and testosterone, both men and women, just different levels. It also drops, but it drops more slowly. It doesn't have that sudden cliff. And the importance of that is that estrogen has receptors. There are receptors for estrogen on every cell and tissue in our body, everywhere, skin, brain, everywhere. So when we go through the menopause and we have these massive fluctuations and then this sudden drop, it has an impact on all those tissues. It's not just the hot flashes and the mood changes. So let's talk about some of the other things that happen today. First, I'm just going to go through a few definitions. Again, menopause means a point in time at 12 months after the final menstrual period. Perimenopause and basically menopause transition are very similar. They're where the cycles change or where the symptoms start. And then really, I'll just use the terms interchangeably because that's how it's really known. We say menopause in our society and people understand what we're talking about. I wanted to also say that this includes all people with menopausal symptoms, regardless what gender that they prefer or that they are, and whether they're trans, etc. So anyone who has menopausal symptoms falls in these categories. Okay, let's talk about a big one to start. Autoimmune disease. Well, autoimmune disease is basically your immune system looking at normal tissue or body parts and thinking that they are a foreign body and attacking them. So this can happen in a variety of circumstances, and there are a lot of different conditions that can occur from this and can impact, again, any part of your body. The exact cause of autoimmune disorders is not known. There are different theories. Some are that they're bacteria or viruses that impact our immune system and cause them. Some are that drugs may change or confuse the immune system. There's another theory held by Gabor Mate that autoimmune diseases are higher in women as a result of us absorbing the stressors of others, suppressing anger, and feeling responsible for other people's emotional states. So that's pretty heavy stuff. But no matter what, we know that women going through hormonal changes, postpartum, for example, and definitely menopause, are more vulnerable to developing autoimmune conditions. 80% of people with autoimmune disease are women. And again, there's a direct link to these hormone changes. So regardless of the theories, and of course, The research hasn't support, like doesn't isn't there to tell us that it's a definite. There are these interactions in our bodies and they're very complex. So again, the exact trigger isn't known, but there is this association with menopause and the upheaval of hormones and autoimmune disease. Autoimmune disease, again, can attack any part of our body. And this is just a small range of the conditions that women and people can get when they suffer from an autoimmune disorder. And it's really it causes things like the destruction of body tissue, abnormal growth of an organ, changes in organ function. So I did promise in my little bio that I would give you treatment options, but obviously I can't give you treatment options for all of this because listen, it depends on the person, it depends on the condition they have, it depends on the seriousness of it, it depends on a lot of things. So but I will say that knowing that there's this vulnerability is something to keep in mind should you be going through the menopause transition and start to feel not like yourself. You have pain in areas, inflammation in areas. It's definitely a good thing to go and be checked. If you get a diagnosis, then the treatment can help prevent damage. So that's a really important thing to think about when you're going through the menopause transition. Okay, menopause also has an impact on our musculoskeletal system. More than 50% of women who go through menopause experience joint stiffness, and I think that's pretty commonly known now, but maybe not. But there are other impacts associated with menopause with the musculoskeletal system, and I'm going to talk about a few specific ones. Frozen shoulder, adhesive capsulitis. You may not know anything about this, and in part because it's not really related to an injury or surgery on the shoulder, but it's related to you could have surgery in another area, or you could have some kind of trigger like the hormone upheaval and end up with this condition. And it's really unpleasant. It is a slow development of pain and inflammation and stiffness in the joint that gets worse over time and then stabilizes to the point where you're not able to move your arm very well for a while and then clears up. This is kind of technical, but over on the left part, you see the close-up picture of the shoulder joint and the red area. Well, that's to symbolize the inflammation and the fibrosis or the stiffening of that joint. So this happened to me. I had surgery, stomach surgery, in the middle of the menopause transition, mine. And I thought, yeah, my stomach's not feeling too badly, but boy, my arm is just so sore. And then over time, and as the days and weeks progressed, my abdomen felt fine, but my shoulder became progressively more painful and like to move and really stiff. I mean, I could put it up to about here. I don't know if you can see that. And that was it. And that went on for months. And I had difficulty brushing my hair, putting on clothing, and I really couldn't exercise at all because anything I tried to do seemed to exacerbate my shoulder pain. So it was terrible and it lasted a long time. I have like a little beanbaggy thing that you can heat up or cool off in the freezer. And I would warm it up in the microwave and put it on my shoulder. And I did that over and over and over again, like for months. I get up in the night to do it. I tried some physiotherapy, which did help a little bit. And I had some low intensity laser therapy with the physiotherapy. To be honest, it didn't really help all that much. So here's what the stages of frozen shoulder look like. And most people go through this, but there can be differences, obviously. So this freezing stage, the movement of the shoulder becomes painful, limited, and it can last 2 to 9 months. Frozen stages, the pain might go away a little bit, maybe, but your shoulder becomes stiffer and that can last for 4 to 12 months. And then the thawing stage, where it starts to get better, can last from 5 to 24 months. It's like, you know, when you're in the middle of this and you're busy and you've got a life, it's really unbelievable. So then what can be done? Well, definitely physiotherapy and range of motion exercises, the best of your ability. Whether they help or not is really whether any of these really have a huge impact on and change it. I'm not sure that the evidence has shown that it does, So corticosteroid injections or numbing injections into the shoulder do help some people. Very, very rarely search for it because reading what some of it doesn't necessarily help. And then what I did, the conservative treatment and time, meaning using comfort measures and anti-inflammatories as required and that sort of thing. But again, estrogen. So the idea being that when estrogen levels go down, the tissue in your body reacts. And this could be one way that your body does react. There's another way, foot pain. I don't know how many of you have experienced, like all of a sudden you're not able to walk very far anymore because your feet are killing you. It could very well be related to estrogen changes because estrogen impacts collagen production. And collagen is a substance that's found everywhere in your body. It's sort of like a, a lining, if you will, of all the tissues between the muscles and the bones and etc. So when estrogen drops, the collagen levels go down. And you know that in your face and stuff, everybody's, whoa, everything's sagging now. So that means though that the joints and the tendons aren't as supple as they used to be. So they're stiffer as well. But each foot has 26 bones and 33 joints and 100 tendons. So, wow, there's a lot of impact there. And we're walking on them all the time. It's no wonder we get sore feet during this time. And when you try to do what you're supposed to do, we got to keep active. We got to keep exercising. And the response is like these feet that just ache for no reason. It's pretty annoying too. The worrisome part though too, and the difficult part is that foot pain can impact your knees and your hips because as you're trying to guard pain in your feet or react to changes in your foot pain, you walk differently, you move differently, and that could exacerbate problems higher up in the joints. So what can we do? Well, you can consider hormone therapy, and you can for all of these if you have a provider and you've gone through an assessment and there's no contraindications and this is something you want to try. Trying menopause hormone therapy or hormone replacement therapy might be helpful for you. See a podiatrist or see somebody about your foot pain because it may be another problem. You may have a condition that needs to be addressed. You may have bunions. You may have, I don't know, heel spurs. That's a fairly common one. You could have other things that need to be addressed and treated. So don't hesitate to go and see somebody about those things because even if the foot pain is partially caused by menopause problems, but also by another problem, getting that fixed or dealing with that might make you feel well. Okay, wear proper shoes. I tell people I've entered into my ugly shoe phase of my life because I need shoes with really good support, ones that aren't going to cause me to exacerbate the pain, like anything with a heel. So the bottom of my foot is feeling all that tension. It's really difficult. Exercise your feet. I'll show you an exercise. I also had heel spurs, plantar fasciitis from working as a registered nurse many years ago, walking those hard floors all the time in the hospital for 12-hour shifts. And the exercises are actually pretty good. And you know what? Icing also helps. So massaging your feet and putting ice on them twice a day helps. Of course, stretching your lower legs. Now, this is really important because everything's connected, as we've just described. So if your feet are sore, your ankles, your knees, your hips, everything, if those muscles and tendons, you don't want to stretch your tendons, but if you keep your muscles supple, etc., then everything around them moves better and it helps your feet. Now, I came across this in my review, recovery footwear, and basically that's to, when you get home, have really, really incredibly cushy cushy things, but they're specific. So if you're looking into this, I'd suggest you talk to a specialist who can tell you what kind of shoe would really help. And sometimes glucosamine supplements, because we can also develop a little bit of arthritis in our feet as well, and that helps to reduce the osteoarthritis pain, etc., and helps to maintain integrity in your feet. So this is one of the exercises where you put your foot flat on the ground and towel underneath it, and use your toes to scrunch up the towel. And that sort of moves the tendons around and strengthens the muscles and helps to keep it supple and normal. Okay, the next part, we're going to talk about something else. Now, of course, again, estrogen impacts every cell, every part of our body. Oral conditions during menopause. Oh boy, this is a big one because I think this is totally unexpected for a lot of people. But 70% of women, for example, end up with dry mouth or xerostomia. And it's really, again, really unexpected and annoying. And you can take there's saliva, artificial saliva products, drink plenty of fluids, avoid tobacco and alcohol, which make things worse. But it's something that you'd have to do on a long-term basis because this doesn't really get a lot better. And it's sort of the new normal, which is so frustrating for a lot of women. Burning mouth syndrome. Now, this is a different thing, and it's very, it can be hugely disruptive for quality of life. It can make it really hard. So it's definitely what it sounds like, burning in your mouth. Now, of course, the trigger's unknown, but they think it's related to nerve damage or hormonal changes during menopause. It can be debilitating. There are some treatment options, such as medications, topical creams, and professional counseling, because again, they may not be able to make huge changes in this condition for you, but be sure to go and see your provider if you're having trouble and persevere with it because this is not okay. All right, after about the age of 20, we build bone density up until about the age of 20, and then after that, it goes down throughout our lives. I mean, we're never going to necessarily put it back on put it back into our bones again unless we're on medication for it. But during the menopause transition, of all the bone density we're going to lose in our lifetime, we lose about 50% of it during that menopause transition. So if you started out with a lower bone density or had a family history of osteoporosis, this is a time of huge vulnerability for you. And it's really helpful to know that ahead of time and be strategic so that you don't end up with problems. Because when it comes to oral care, you can lose teeth, and nobody wants to do that. So, of course, the lifestyle stuff. You get enough calcium and vitamin D in your diet to maintain your bone density as much as you can. Exercise with weight-bearing exercises, not necessarily helpful for your jaw, but it certainly helps the rest of your body and balance. It helps. And quit smoking. If you're still smoking or vaping, please consider quitting. It's a major risk factor for so many things, but definitely for osteoporosis. And it is an independent risk factor for tooth loss. So it's really helpful to consider that. Okay, something I noticed I don't like at all. Everything tastes differently. Everything smells different. And and you know what? The reviews that I read say it's just a nuisance. It's not a cause for concern. Well, you know, it is actually. It's very, very disturbing to have gone through your whole life with a certain amount, certain flavors and smells, etc., and then have it completely different. The suggestions are to experiment with different flavors and spices, etc., to find combinations that you might enjoy, to find different flavors that you may not have liked in the past, but now you like. And unfortunately, it often means to avoid strong tasting things, but it's really a personal choice. Geographic tongue is a weird thing where sort of almost out of the blue, you get red lesions on your tongue and they sort of pop up and go away over time. And again, they say they're harmless, but they're itchy and painful sometimes. It's again related to hormonal changes, thought to be, but the exact cause isn't known. Home remedies sometimes help. So drink plenty of fluids, avoid spicier or salty food, and use a soft bristled brush. There are potential things for relief if that's not really helpful. You can try oral antihistamines, topical steroids, but it really depends on the person. And of course, if there are more alarming symptoms that might be something completely different, like difficulty swallowing or burning or bleeding or fever or anything like that, you've got to see somebody. You can't just say, oh, well, geographic tongue, it's fine. No, no, get over there, see somebody. I read another interesting thing that the pH or the acidity in a woman's mouth is different than a mouth of a man. And this changes again during menopause. And this puts us at risk, or sorry, vulnerability for things like changes in our gums, gum disease, and gingivitis. And again, it can also lead to tooth loss. So oral care, brushing, flossing, seeing your dentist, hygienist on a regular basis are hugely important. Hydration, and again, reducing alcohol, and we can all say it together, stop smoking. All right. Obstructive sleep apnea. Now, people know this to be a man's issue. They know it to be for obesity. But what we don't know is that 20% of women postmenopausal have obstructive sleep apnea, but it's highly underdiagnosed and undertreated. The problem is it is hugely linked to cardiac arrest, and cardiac disease. So it's really important to, if you have any signs or symptoms, to be checked for it. Now, before you say, oh, well, I'm not overweight and I'm not obese and I'm fine. The other thing to understand is that when estrogen levels go down, the musculature of our mouth and our throat and our pharynx softens, and that puts us more at risk for sleep apnea. And another thing is studies have shown that women have less reported sleep apneic episodes. And they think that has to do with their partners, because women are up all night. Most women I know wake up during the night, and we hear our husbands or partners, sometimes if they're men, if they are snoring and they have that pause in their breathing, that could be apneic, and we tell them. It doesn't often go the other way around. So the thinking process is that these things, this diagnosis is being missed in women because there isn't that same acknowledgement or understanding or witnessing of the apneic episode. So sleep, of course, treatment for this can be weight loss, depending on how severe it is, can be CPAP machine. So just in case you've never seen it before, this is what geographic tongue looks like. And again, the lesions can be anywhere, and it's very characterized by the deep grooves and the little blotches, and it's annoying. If you do find that you have this, double check. Go and see somebody, make sure that that's what it is, and you don't have something else that can be treated that actually is a bit of a problem. But, and I promise you, this is me. I promise you, I don't have every condition that I'm presenting tonight, but I do have sleep apnea. So this is when I was tested. They hook you up. There are machines, I think, now that you take home with you, but at the time and during COVID, I went and was hooked up to everything. And what you don't see is the thing that goes on your nose, and you're in a sleep lab. And, I don't know. I was sure I didn't sleep at all. I was sure I had zero sleep that night, but apparently I did. And I had a lot of apneic episodes. So now I have a CPAP machine. And I hate to say it, but it was one of the best things that ever happened, because I personally sleep a lot better and much more rested. So, I mean, there are some benefits, I guess. Okay. Last one we're going to talk about is hair loss in menopause. So again, let's talk about estrogen. Well, we don't just have estrogen, do we? We've got progesterone and testosterone. But let's talk about this testosterone called androgens. There are other hormones that are part of that family of hormones that are called androgens. And what happens when estrogen drops, again, it drops really quickly, and testosterone doesn't drop quite as quickly. So suddenly the ratio of estrogen to your androgen level is a lot different. You have much higher percentage of androgen than you used to. And that causes some issues. One is, we talk about hair loss, but actually you can react by having symptoms of too much androgen. And that can be like acne or hair growth on your face. Yay. Isn't that wonderful? This is what we have to put up with now. but it also sort of triggers some of the conditions that relate to hair loss. And some of them are female patterned hair loss. So, male pattern baldness, but they have female pattern hair loss as well. And it is characterized by the widening of the part like this. And again, it is most commonly found in postmenopausal women, attributing to the changes in the estrogen and the androgen levels that we just discussed. There does appear to be a genetic link, much like men, but there's also environmental influences like smoking, say it again, but also diabetes, hypertension, low iron, low vitamin D, and high levels of stress. So the hair thins on the crown, widening of the part. It's typically not as severe as with male pattern baldness, but still extremely disturbing when it happens. Your primary care provider may want to check some things like your thyroid level, find out if you're anemic, find out if you have some other hormones that are raging in your body. Check out your blood pressure because all those things can impact hair growth and hair loss. The first line treatment for a woman is a topical treatment, hair growth treatment, and it helps prevent further hair loss, but it doesn't help hair growth, hair regrowth. There is a medication that can be taken off label for women because, of course, everything's off label for us for stuff like this because it has to do with androgens. So it may help with some hair regrowth. Again, they don't know the exact mechanism because even when women are taking hormone replacement therapy, they don't necessarily get the hair regrowth. So it's pretty complicated. And again, science hasn't figured out all the reasons. Okay, so this is a comparison of female pattern hair loss and male pattern hair loss. But there are also times in a woman's life, and many of us will know this, where with a major loss of estrogen, there's a shedding of hair. And it occurs also with a major life stressor, a chronic condition. Some medications can cause it, and it's a sudden shedding of hair. So if you've given birth and you may have recognized that during your pregnancy, your hair is beautiful and lush and long and flowing and great or whatever. And then after the baby was born, it was like you're pulling it out like this. That's an example of it. And the same thing can happen during the menopause transition and menopause, but in this case, it comes back. So it's important to kind of know what the issue is when you're dealing with it. And there is one more, and this is specific medical condition, frontal fibrosing alopecia. It happens mostly, most people who get it are postmenopausal women. The exact cause isn't known, but basically it means that you're losing your hair on the front and sides of your scalp, your eyebrows and eyelashes, and maybe some other body parts. Treatment may be slow, but hair loss can never be just restored. It can only be prevented from getting further. So if you find that you're losing hair like this, definitely seek assistance right away. And if you do get treatment, it tends to be things like antibiotics to reduce inflammation, sometimes cortisone injections or creams. Again, the same pill that's used actually for prostate issues for men that sometimes is used for female pattern baldness off label could also be used in this type as well. And the lotion, Midoxanil, for hair regrowth. It's very, very difficult. And beyond treatment for these, hair loss, hair is a huge part of our lives for most of us. I mean, I'm not quite sure what to say. It's very distressing to lose hair, and but there are many other types of things that you can do. Certainly, wigs and hair pieces and sprays and that sort of thing. And it's really going to be a journey for each woman, depending on what she experiences and what she has. Okay, so that's actually the end of this, the presentation part. I wanted to let people see the link to the website that I have so you can, if you have any interest in reading some blogs or being linked to videos and courses, you can check it out.